Good morning, everyone. For those of you who are in Western Africa, and good afternoon for those of you who are from Eastern part of Africa. I'm really very grateful for the Smile 10 and for West African College of Surgeons to organize this so that I discuss a topic which is close to my heart, a variant of the Nordoff triangular vermilion flap in correction of the Vermilion. I would the outline of my discussion would be that I will go through historic events in terms of lip Vermilion repair. I will discuss a bit on Millard's method, and I will discuss briefly on the shortcomings of the Millard's straight line repair of the Vermilion. And then I will go through historic events which caused the modification of the Millard's method by Noordhoff. And I will discuss on the reasons why Noordhoff designs those modifications. And then also after Noordhoff, surgeons have come with the modification of Noordhoff's Vermilion triangle so that we get a good, full, and symmetric lip. So I will also discuss all those people who have modified it, the way they modified it, and we'll finalize on the current status of the Vermilion repair. So to go briefly on the anatomy, as you know, the Vermilion is a very delicate, unique structure with its unique shape and also fullness. So when we repair, we need to respect all this so that we get a full lip. And again, also the symmetry is also very important. So I won't go in detail in the anatomy of this, as most of you are familiar with, but respecting especially the Cupid's bow is very important. And in the fullness in the Vermilion is also very important, especially on lips which are fuller than some lips which are less full. So my discussion will go through this. So as you all know, the Vermilion is a free margin of the lip below the white roll covered by transitory epithelium. It is characterized by a mucovermilion border, which is called also the red line. And one thing to note is that the dry Vermilion is at its widest point at the peak of the Cupid's bows. This is a very important landmark when we discuss about our surgical interventions later. So just to discuss few of the anatomy, you can see that the muscle is a very important structure in the formation of the lip and in the form of the lip. It's not the skin. It's so very important really to realize that at the lip side, so the discontinuities of the skin or soft tissue, but the main deficiency is the soft tissue, the muscle and the other parts of the bulk, and we have to consider this when really repairing the deficient part. We should not just consider the skin, but we have to give a higher attention to feeling the bulk with a muscle and all structures of the lip. So there are anomalies, there are the problems, anatomical problems, which we need to correct, as you all know. And my discussion today will not be really about nasal deformity or about cleft in alveolus or about the muscle tied to the alar base and the like. But I would really like to focus on this Vermilion part. It doesn't matter whichever way of surgical repair you use, whether Millard or any triangular or any variant. That is not my really point of discussion. My point of discussion will be just the Vermilion to know, to give you in advance. So again, to go further on the anatomy, the muscle deficiency need to be noted, which we need also to consider when doing the surgery. The abnormal insertion is noted, and in all kind of repairs you do, you of course align the muscle in a horizontal way so that you reconstruct the defect. But for Vermilion also, the repair of the orbicularis marginalis muscle in a harmonious way is very important to have a good shape and fullness. So the goal of surgery, as we all know, is to create as normal aesthetic and functional and repair as possible. So ideal result will be gained only if we really go on address very important basic information. So my really discussion today will be mainly to avoid this kind of deformity you see on this patient. So I will be discussing, and the deficiency is not just the width of the lip, but also the anterior posterior fullness. There is also defect. So whenever we think of really avoiding such a defect, we have to see it in two dimensions, anterior posterior and the thickness of the lip as well. So the reason really I'm very much interested on this presentation on the repairing of the Vermilion deficit feeling is because, just let me take you a little out. About like 15, maybe 20 years ago, I was in Bergen, Norway. And during my stay there, there was a time when all cleft patients operated at the Bergen hospital are seen at least once or twice annually with a team of surgeons and also orthodontists and other specialists, pediatricians, and the whole holistic team is seeing them, and all patients from all over the country are coming to be seen by these experts. And it was very interesting. There were all patients from all range of years, from month 6, 9 to about 18 years, or even some even older. And I was so impressed, and the attendance was really very full. And I was told that for all these patients and parents, all costs are covered so that they come to see the doctors. And then they have all the facilities. The hotel is arranged for them. And when I attended this meeting and I saw the files of this patient, it's so thick. A lot of pictures all through every year, different pictures, and most of them have multiple surgeries. And of course, when they are adults, they go for perfection. So some have 4 or 5 surgeries to get a perfect result. I mean, this is the ideal scenario, my colleagues. This is ideal scenario, but our scenario is very different. So we cannot really have follow-up is a very problem. I think it's in most African countries. Once you fix the patients, the parents have other priorities and in life. So they really, once it is fixed somehow fairly, then they disappear and they don't show up. And I really get frustrated when I go around in town, in Addis or other towns. I see patients with really secondary deformities which could have been corrected, but I even advise some to come and very, so the first the best chance for good result is during the first surgery for us, no question. So if we compromise on qualities of the first surgery, then we are going to stay with so many patients with secondary problems. So now let me go to the right topic. So what do I mean when I mean a Vermilion deficiency? You see, I present in most of my slides adult patients because for demonstration it's easier. So you see this is a Cupid's bow. The normal side of the Cupid's bow, this is a filtrar tubercle. This is a normal Vermilion. And you see how deficient it is here, very obvious. And the deficiency starts from the middle. And the deficiency, you know, it increases as you go more to the cleft side, more to the lateral side. So you see, at the end of your surgery, your aim is to bring this similar to what it is on the other side, to have the mirror image of this on this side. So very basic, you have to fill this deficiency in one way or another so that you get a symmetrical Cupid's bow region, a symmetrical lip. So when you repair, or do you repair, you have to have the two-dimension thinking. You have to repair the width, and also you have to repair the anterior posterior thickness of the lip as well by putting bulk in here. So when you do that, you have enough structure and here in Millard, you know, after the new Cupid's bow side on the peak side on this side, this is discarded. So you have to use the structures on this side instead of discarding to insert them in here so that you have a symmetrical Vermilion below the Cupid's bow on both the peak of the Cupid's bow on both sides. This is basically what I'm going to discuss with you today. Let me start how Millard, you know, Millard has revolutionized the surgical aspects in so many ways. But in this semantic thing, when you see, you think everything is in order. This site is deficient, but this deficiency is corrected maybe by pulling or whatever you do without any intervention. It cannot come to this level because we know that the muscle is deficient in here. We know that other structures, all structures of the lip, submucosa or whatever, the subepidermis, everything is deficient. So unless you feel it, it will show up one day with a notch. So this is really very important. So Nordoff realized this, and he came up with this a modification of, instead of straight repair, instead of this straight repair, he came up with a modification which I will be discussed very briefly. So again here in Millard's, you see the non-cleft side below the Cupid's bow, half, non-cleft side half, and this, you see the difference. So this needed to be supplemented. It's not done with all. So the known setbacks of this procedure is a notch in the Vermilion. So, you know, the notch is described as a depression of the Vermilion on both sides of the repaired cup, as well as a break in the free border of the lip. And with straight line closure, I am certain that it's very difficult to avoid notching in these patients. So in 1984, Noordhoff came with the idea of bringing Vermilion from the lateral aspect, inserting it to the deficient side. So, you know, early in my practice, this was in the late 80s and 90s, I really was fond of Nordoff's triangular flap. It really solved many of my problems, and I was really very pleased. I was fond of it, and I was one of the advocates for it. But after when I have been practicing it, I realized to see certain also difficulties in the Nordoff triangle activities, and I will discuss briefly those. So, yes, it is addressing the deficiency, but the problem is geometrically, I felt it's a bit, you know, I was not comfortable a bit on that. So some of the drawbacks I saw in the Nordoff is, you see, its flap starts from the white border here. And the triangular flap base is this big. This is bigger than the deficiency. You know, the deficiency, if you see here, the deficiency is this amount to make it symmetrical on the other side. So it's not starting from zero. You know, but this flap is assuming that there is nothing in here, it starts from zero and inserting it in the defect side. So this was my concern, and by doing this, it was distorting the lip, and it was not geometrically accurately fit to replace the deficiency. This was one of my points which I was not happy with the Nordoff render. And then also, as I have discussed earlier with you, you know, the deficiency starts from the midline. We discussed, we agreed, it starts from the midline. And this is gradually increasing, and the highest is at this side. So once we have this, the feeling of the deficiency should reach the midline. I was not happy with this, so I started really to extend my incision to the midline and the flap to extend to the midline. So that, you know, so this was the drawbacks I really have been. So, however, now, the flap base is greater than the vertical deficiency, as I've already discussed. And the flap is shorter than the horizontal deficiency, as I have already discussed. It was supposed to reach here. And the other point I was not happy with the Nordoff, at least the way it is explained, or the way I have seen my teachers have been doing, it doesn't incorporate of much bulk in here. Because the deficiency is not just only small bit of vermilion skin or a small subcuticular tissue also, but it should be a full thickness. So I saw this as a drawback. So it does not incorporate enough bulk. And the other thing which I was also not very comfortable was, like you see, if you see the opening here on the medial aspect, the triangle, the two sides of the triangle are not equal. The two sides of the triangle are not equal. Whereas the Nordoff triangle, which is to be inserted in this, is of equal triangle. And this geometrically, I was not comfortable actually, because when you put a symmetrical, when you put a two sides equal triangle into unequal ones, then you get some bulge in one way or another. So this was also one of the points I really wanted to discuss. And the opening at the deficient side triangle, two sides do not have equal lengths. So this was the base of myself and also other people who tried to modify the Nordoff method. Then, as I have been practicing my own way, some publication came out. And Rajesh, in 2004, addressed some of my concerns in this aspect. He modified really the Nordoff with his own modification. So the points he made was, like as I already mentioned earlier, the base is bigger than the defect. So Rajesh has recognized this. So he exactly put the base of the triangle as filling the defect, the missing part of the medial aspect of the lip, so that, you know, it fits very well. So to do this, you know, in the Nordoff, the flap starts from just the white line, from the white border. But in Rajesh, he comes straight 90 degrees to the lip axis, and then he cuts to the desired point and put the flap horizontal length is reaching the midline as you see it. He answered also this issue of my concern. Now he's feeling the full horizontal deficiency. And then, of course, as if both in Noordhoff and in Rajesh, the lower part of the flap always ends at the Vermilion border or at the red line. So this is the same as in Noordhoff. So he has really improved my two concern issues. One is the base is equal, the base of the deficiency of the flap is equal to the deficiency, and the second is the horizontal length of the flap is reaching the midline. So Rajesh has come up with these results. Now, there are two issues which were not addressed, my issues by Rajesh, and those are: one, you see the defect is as a triangle, a triangular defect, with the two triangular sides are not equal. This is one of my concerns. On his, so, and then he has not described how much bulk he is putting in this defect. Rajesh has not described much. So really the width part deficiency is addressed, but the anterior posterior aspect, how it is addressed, I was not clear. And in the demonstration, and that was not really described. So I still have two issues on the Rajesh modification, because how much bulk we need to insert, and also this two-side triangle is really producing a bulge after repair, or the bulge will remain lifelong on that aspect. Rajesh also has really recognized that really he is trying to insert a two-sides triangle equal one with to a defect with not similar to it. So he recognized it and he came up with another modification later in 2015. So after describing this, I will really go through how I really I'm doing it on my way. So to just summarize on what Rajesh thing where I thought maybe need some certain improvement on that aspect, is that it didn't consider the anterior posterior or fullness thickness correction. This is one of my things. So again, you know, the horizontal incision on the deficient Vermilion side follows the red line, creating a non-isosceles triangle, or meaning the two sides of the triangle are not equal. And he used of an isosceles triangle to correct the deficiency, which was not essentially an isosceles. With this, I really started in 2000, 2004, and I also went through Rajesh's thing, and I presented my modifications at international conferences. In 2010, I presented it in Seoul, South Korea, at the 6th Congress of the International Cleft Lip Panel, and then I met Nordoff himself, and really he appreciated my thing, and this was encouraging to me. I presented my modification also in 2008 at the World Craniofacial Conference in Dallas, Texas, and again in 2008 at Changgung International Forum in Taipei. And in 2009, I presented my modification at the 11th International Congress on Cleft lip in Fortaleza, Brazil. So my way is, most of it is taken from both Rajesh and Noordhoff. It differs only in a little aspect. So the base of the triangular flap here equals the amount of the maximum deficiency here. That's how Rajesh is doing. And two, the flap starts below from the mucocutaneous junction or from the red line. This is how Noordhoff does. This is how in Rajesh method is described. And the flap does not reach the white border. As you can see, this is how Rajesh is doing, so I do it the same way. So horizontally, the flap reaches the midline. It reaches here. So this is how Rajesh does, but Noordhoff is a bit short of it. So, and again also, the pictures I show here is after Millard's procedure, but it doesn't matter whichever method you use, you can really repair the lip insert the vermilion in such manner so that you respect the fullness and the symmetry. Though my description is in Millard's, it doesn't necessarily be that way. So by doing this, I really get very satisfying symmetry and fullness. So it's all about discussing this. So to go a bit in detail, how I go about, I won't discuss on the pointings of the Cupid's bow, but I will mention a few things. So my incision on the medial segment of the cleft is that I really mark my featured Cupid's bow, and I really draw and then make an incision 90 degrees to the lip axis. And then after doing this, at the red line, I do a horizontal incision. I am not following the red line here. I'm really following the axis of the lip, and my incision goes directly to the center, close to the tubercle, the filtral tubercle. I will make my justification then why I'm really considering this. So basically, I open this. And then when I do open this, I don't just open the vermilion skin and a bit of subcutis or so. I just open the whole lip. Because as I already mentioned, the deficiency is not just the whole thickness is deficient. So I just open it as a fish mouth. I just open it like that in this incision. And then this is ready now to accept bulk from the lateral side of the deficit. So now these are some of the additional points which I have considered. So now on the lateral side, let me just describe with you how I decide on the future Cupid's bow peak on the lateral aspect. You know, during our early training, we were really told to measure from the fissure to this normal side peak of Cupid's bow and apply the same measure and decide where to put your mark on the cleft side. I disagree with this very much because, you know, pathology, on the pathology of the lip, this side, the muscle is really disconnected with the smother muscle, and it has contracted. When it contracts, the lip also contracts. So you cannot compare orange with apple so that this measurement can apply for this. So rather, for all of us, to mark this point, I think the very crucial point to discuss is we have to have a mirror image of this on the other side. So as I mentioned earlier, like You know, the vermilion, the lower margin of the lip, this thickness is at the highest at this Cupid's bow. This is at the highest thickness. The same will apply on the other side. So I am dictated by the fact that I take this mark as the thickest part of the vermilion. So I mark there. This will be my future big Cupid's bow on the right side. So once I get this point right, now if I come here and I bring this point here, I tell you it will be a big mistake because I'm going to use this deficient vermilion side, and again I cannot avoid notching. So this is a very crucial point in this repair. So once you mark this, then I decide on the level of the flap base side by the amount of deficiency I calculate. So as I said, it's the lower part starts from the red line, and I decide this point by really measuring how much deficiency there is to fill here. It's very simple. It's just you really subtract from this distance amount with this distance, then you can see how much deficient is it, or you can measure this, and then minus this, you can really know how much flap you need. And then also the horizontal length of my flap will be based on this distance. So I make sure that the tip reaches the midline. So I really do my incisions in here. And then when I put this flap, you can see it here. I don't just took the skin or subcutis and like, no, very thick one. Because I know I have to fill this deficiency with all the structures. Maybe not mucosa is forgiving and we can play with it. So this is very important in my method. So just a closer, similar to what I already mentioned. So you can see in Noordhoff or Rajesh, this flap is inserted here. It is inserted in here. It does not follow the horizontal natural place of the muscle, as I am doing also muscle repair in here. So as you can see, this flap is not coming here. It is rather has come straight in there, and the muscle falls to its natural place. And then also, the opening you make is of equal triangles when you open here, instead of opening downwards like this, following the line. So when you go through and you open straight in there to the tubercle, now the triangular flap you have created comes fitting very well to the deficient side, and the muscle harmony will be continuous. And once you respect the muscle, the skins will really come together very well. So this is just the drawings, and more or less similar to this. So basically this will, so my additional things are 2 points in what Rajesh has done, just 2 points. But here to emphasize, you see, if you have a harmonious muscle in here without a skin, you know the lips look like a lip, even without the skin. So this is very important to note. So my horizontal incision comes like this. It's not like this as in Rajesh or Nordoff, but horizontal. And you see the same way as it looks. And a bulk is inserted in here. So you see the deficiency and the fullness is addressed. When you do this cut, back cut on the cleft side medial aspect, or there is always a redundant mucosa, which you will finally cut as you go. And then always I don't close the mucosa from inside when I do my millard. I leave like 2-3 stitches before the margin, so that I will finish it at a later stage, at the last, after really settling with a vermilion part. So I close it as so to summarize, this is Rajesh. This is my proposed method. So as I mentioned here, there will be a bulk which will be cut at a later stage, and then you get. So with this method, I tell you, I'm very satisfied in regard to the Vermilion repair and fullness. So I shared my experience, just not by really discussing this in international meetings, but with my colleagues in Eastern Africa and other places also. Interestingly, many of my colleagues have bought this idea, and the feedback I'm getting is very much encouraging. So, like in Democratic Republic of Congo, I used to operate going there with different parts of Congo, and in Goma, I used to operate with a surgeon called Polepole Chomba. And really bought this idea, and he has really practiced, defined it, and then after certain years, I found him presenting this modification in an international meeting in the USA. Again, also really to share with you my experience on this, like maybe 10 years ago, something like that. I had a visit in Senegal, Dakar. I used to work for Amref Flying Doctors there, and I went to visit the Amref office in Dakar, and the head of the office then arranged for me to visit the university hospital to see the Cleft programs there, to meet with the professor there. And I went at this clinic in the university, and then met with a professor, and I tell you, wonderful work he was doing, a partner of Ismail Khed. And when we went with another colleague to visit his center, there were patients really lined up, some post-op cases, good results actually. And I congratulated him for his good results and the like. And I was impressed. I was really surprised when he told me that he has seen, as he was in East Africa some time, and he was exposed to the method, and he's using my modification method, and that he was happy. It was pleasing for me. So it has really gone up. It is really multiplied this kind of work, which I'm very happy with. So I'm deliberately demonstrating adult patients, which is really easy to demonstrate and show. I'm really very pleased with the results of it. And I think during this meeting, I would like really to know how other surgeons, colleagues of mine have felt with this Nordoff modification, with Rajesh modification, or with mine modification, because notching is a very important issue in our setting. So certain results. Trust me, you won't be disappointed if you really go on using this method. So Rajesh modified his method in 2003. He recognized his drawbacks, but he brought a model. I have put this in the reference list so you can really see. Instead of the triangular flap, he was worried about the scarring of it, which I am not much worried of, because the Vermilion is a very forgiving tissue. The Vermilion scarring is not major problem, at least in my hands. But to avoid, he avoided the triangle so that to avoid a two-sided scar. And he came up with this kind of modification. You can go in detail, see it. But my concern with this modification is that still, the amount of tissue is going to discard here is really quite, I'm not satisfied. I can't comment now because not many results have been demonstrated in this, but in his new modification also, he has not discussed how much bulk he is putting in it. You know, he's discarding all this, and he's putting this as a flap in here, filling the deficiency. So he has compared it with Millard's straight line repair. Of course, he's getting better function, but he has not compared it with Nordoff's modification or with his previous modification. But he mentions that he's really satisfied. So now, you know, one thing I really want to discuss with you is that the technology is so advanced in terms of prevision. When you see computers, when you see vehicles, when you see other structures, you know, its precision is really very interesting. But how come it has not come to our own tissue, you know, precision issue? So, but there are certain individuals who are working hard really to refine this. Fisher, David Fisher is one of them. He had really come up with some modification in 2015, but did not address much on the Vermilion as I am concerned. He's using, or later on Raymond has come with certain modifications. I've really had the chance to operate with both of them and really appreciate their work. With many modifications coming up, but the Vermilion deficit issue feeling still is coming behind. So a lot of further research is really needed. And maybe I will be behind in like 3-4 minutes with apologies. So I just came across with one from Nigeria paper, which describes, compares triangular flap with Millard's procedure. It has really compared it very well. So my purpose of presenting is, but he has not compared the Vermilion fullness on both aspects because not much attention is given to the Vermilion. But in the future, I think we need to give attention to the symmetry and fullness of Vermilion in any major things. So Nordoff has also described this flap for bilateral. I tell you, I have used it only in few cases. When you have no muscle deficiency in here, you can really try a bit of flap from both sides, your triangular flap and repair. But in bilateral, as you see, the muscle deficiency is very great. So we should not attempt this triangular flap in bilateral. Rather, we should borrow, otherwise we'll end up like this. So that's how we should borrow muscle from both sides and bring fullness. If you do this kind of surgery called Manchester's method, which is tempting, repairing a deficient prolabium, bringing the lip, trying to bring together, this is eventually how you end up. So we need to avoid this. Rather, we need to use a method where you can bring enough bulk from both sides so that you repair. In the center, you get such a kind of repair. So Vermouth triangular flap is not advised. But if you bring both sides enough bulk of muscle, again, you will be very happy with the fullness. You see, revisions, we get a lot of them, and that still be corrected with this similar muscle attention method. Notching is a problem, I tell you. It's so frustrating to see many of our patients who have been operated through the AIDS, you see them in the market or other places, they have this kind of deformities they are going with around. With primary surgery, all this could have been avoided. So these are secondary deformities. Still, you can use Nordoff triangular flap or my modification or Rajesh modification, whichever you like, to correct this and you get good results. So I'm just close to finishing. Dr. Adenola, a good friend of Smile 10, a good friend of ours, you know, he has done thousands of surgeries or supported thousands of surgeries. And he had a motto of really decreasing the number of notches in his department, and he has succeeded to do so. He has really thought we need to follow his footsteps so that we really audit our work and see why we are failing. We are getting so many notching of our lift repair. Finally, I would like to thank AmRefer Health Africa for giving me the opportunity to go to many places, operate, see patients. And I would like also to really thank Smile 10 for giving us this opportunity of supporting patients. Time is up. I have put a reference for you where I really encourage the young doctors to give high attention to this Vermilion correction, because the fullness to our lips is very important. Very crucial cosmetically, also in terms of function. So I thank you very much and looking forward to discussing with you the remaining 15 minutes. Thank you very much for your attendance.
Thank you very much, Dr. Asrat, for this beautiful presentation. I think we can now take questions from the participants. As of now, we have 62 participants. And I want you to please submit your questions to the chat room. Doctor, I don't know who owns this one. He said, how many cases will be needed to approve the modification? Can we take them one by one, or we read out the questions so you can take them one by one?
As you wish, sir.
Okay, let's take them 2-2. One says, how many cases will be needed? Okay. Dr. Udiche says, thank you, sir, for the clear presentation. I want to understand if the triangular flap cut on the lateral side, which you said would include muscle, could drop down with the abnormal attachment of the muscle. Hello?
Yes,
Am
please.
I clear, please? Am I clear?
Yes, please. I hear you.
Can you take those ones, please? Can you take
All
those
right, thank you.
those two questions? Yes, thank you.
Thank you very much. Now to start to answer the first question, I think the way I understood it is really to have, I understood it in two ways, the question. Maybe certain explanation is needed. One is, how many cases does a surgeon need to really have the learning curve? How many cases does he need to do? This is the one way I understood the question. The other way is, if he wants to be a research work, how many patients he need really to have at least to follow up for some time and really justifies that this method is working. So I will try to address on both aspects, whichever way the question is. So now, as I have already explained to you, this kind of modification is very basic, simple, and I can say see one, do one, teach one will work perfectly for this. Especially, you know, non-adult patients or during, if you do really one, this is a very basic geometrical kind of thing. It's not complicated. It's easy to show. It's easy also to learn. So I go for do one, see one, do one, teach one on that aspect. But if the question is really to address if one has really to justify that this method is superior than other method, I think this is a drawback that we need to have a long-term follow-up. That's the main important issue rather than the numbers. So we need really to compare. This is a gold mine field of research. One can compare Nordoff modification with Rajesh. One can compare Rajesh's modification with mine. One can compare my modification with Nordoff proper. Now, for the Vermilion, comparing it with Millard straight repair does not make much help, because we already know enough data that Millard's straight line repair will eventually end, because we have not corrected the deficiency, eventually end with notching, no problem. So the follow-up is the most important thing. But if one really has the capacity and the potential and the resources to do such kind of comparison and came up in 40, 60, 100 patients, comparing from each group would be ideal. And then now you give to the rest of the world evidence-based data really to answer this problem. So the second question is not actually part of my topic. What I really meant during my discussion is that, either in Millard's method, you are using the rotation advancement flap, or in other methods, it's obvious that the abnormal insertion of the muscle from the nasal base is detached and then brought together. The muscle on the two sides is brought together. So I just mentioned that, but that's not my topic of discussion for today. My focus is mainly on the vermilion, which is below the white border of the lip. Okay?
Okay, thank you, Dr. Asrat. Dr. Abdulkadri Bello asked a question that it should. He said, thank you for the presentation. If you propose a modification, if you propose the modification, will it be called like Majesty modification or Nordoff, or will it carry your name as like Majesty triangular vermilion flap insertion? Is the question clear?
Not really.
Okay.
Can you say it again, please, Professor?
If you propose the modification, will it be called like Majesty modification of Nordoff, or will it carry your name like Majesty's triangular vermilion flap insertion, or another name?
Okay, thank you very much, Dr. Abdulkader. We need to give credit to Noordhoff on this. He's the one who realized the Millard's shortcomings. And then I think we need also to recognize Rajesh's modification. Now, if you really insist on putting my name, I think I would go for first Rajesh's modification, by me. So, or Nordoff's triangle modification. So I think we need to give our recognition for those who have originally started to address this problem, and I do great respect for Nordoff, and we are just putting a little bit in his big portfolio. So I really understand it that way.
Okay. Dr. Olusola Amole said, great presentation, sir. Please, could you make a comment on this? I think the post-repair notching associated with Millard is secondary to inappropriate surgical cutting techniques intraoperatively. He said, I think the post-repair notching associated with Millard's is secondary to inappropriate surgical cutting techniques intraoperatively. How do you respond to that, sir?
I think we need to be clear here. When I mentioned Millard's, we need to give due respect to the rotation advancement flap. So what I referred in my presentation is, in the Millard's repair, I am mentioning the straight line Vermilion repair. I have been always doing Millard's method. But on Millard's method, when I repair the Vermilion, I use the modified Nordoff's method. So the Millard's shortcoming is on the Vermilion part only. But again, I won't go to detail on an issue which is like an ocean. The Millard method, the main one, the rotation advancement flap, has also different modifications. I don't want to go on that. I don't want to confuse you all. I used a modified Millard's method for the cleft, unilateral cleft lip repair. And then my only additional input is on all these discussions I said about the Millard shortcomings on the Vermilion, not on the whole lip. On the Vermilion part, straight line closure, whatever you do, whatever miracle you do, if you don't feel the deficiency, that notch will show up again. I tell you, this is for sure. But maybe in the children, you cannot see that deficiency at that immediate postoperative view, or in your immediate postoperative picture, it might look fine, perfect. But when the child grows, that deficiency is efficiently growing, and as the child grows up, the deficiency will show it up, will show it itself. And I tell you, let me tell you one story on this aspect. During my studies in India, on Tuesdays, we had a cleft clinic. I was a registrar then, with the registrars, 3-4 of us, sitting and waiting, patients coming for follow-up. I tell you, my colleagues, Indian registrars, when the patients are like 6 meters away to come to our clinic, to come in the door, you know, they discuss, oh, this is Dr. X lip. This is Dr. Y lip. This is Dr. Z lip. You know, just by the look of the lip, 10 days after operation, they can tell who operated this patient. You know, the method we use is very important for the outcome of it. So immediately it might look fine, perfect, but these details are very important, especially, you know, for our generous lips. The attention to the fullness is very crucial. It's very important. This is a message I want to put. Symmetry of fullness is very important, and we need to really be very meticulous on this so that we have good, very good results. I tell you, with this procedure, we have done thousands of operations. In what the smile drain has done so far, I tell you, in Ethiopia alone, we have more than 30,000 cleft surgeries done through the support of smile drain. And you can see all the data is there. You can really do a research on that aspect. So we don't have follow-up. We have also adult cases, so many of them. So this detail is very important. And even exploring the smile train data, we have over 100,000 patients operated in all African countries through the smile train. We have enough of data and pictures in there. And in Eastern Africa, we have so many thousands dead. So we have the data. We can really follow patients, see patients which are operated under my modification as well, and then also compare it with maybe some other places, countries which are done with immediately straight line, Millard, Piper, and others. So please don't quote me that my misstating as the Millard's method is discredited. No, that's not the case. Thank you very much.
Thank you, Dr. Asrat. You have many congratulatory messages on the chat room. I think to save time, we will not take them one by one. But I think there are so many of them, and I also thank you for this great presentation. Please.
Thank you, Professor Akanola.
Thank you very much.
Pleasure, sir.
Yeah. Nicole. Hello,
Thank
Nicole.
you. Hello, Prof. Thank you for the moderation. Thank you, Dr. Asra, for this excellent presentation. So we are closing our session today. See you tomorrow. Thank you for attending. Bye-bye.
Bye-bye, bye-bye.
Bye-bye.
Bye.